Welcome to the HealthManagement.org DigiConf Healthcare 4.6, Advancing Healthcare, Digital Solutions and Smart Hospitals. Our Editor-in-Chief, Professor Werner Leodolter, will moderate the session. Our panelists include Professor Florencio Travieso, Co-Director of MSc in Health Management and Data Intelligence. Diane Whitehouse, eHealth expert and editorial board member. Dr. Fenna Heyning, a health innovator and director of STZ. Wolfgang Schinagl, Head of Information and Communication Technology, Styrian Economic Chamber. And Professor Henrique Martins, University Institute of Lisbon and editorial board member. Let us now welcome the moderator of today's DigiConf, Professor Werner Leodolter.
Hello, everybody. Wish you a nice afternoon. I think it will be a very interesting afternoon. You just saw the panelists. Welcome to the panelists from my side. So we have an interesting topic, Healthcare 4.6. When I read it first, I also asked myself, what do we mean by that? And so I thought, what is Healthcare 5.0? We're obviously moving there. And from my point of view, that is the right mix of a real-world physical interaction-based care and virtual care, with the emphasis on patient-centeredness, on prevention, and on leading us to a personalized and precision medicine. I'm convinced that many tools for Healthcare 5.0 are available today in a high degree. All medical and diagnostic devices are network ready and so on. We are getting lots of data. And what's not so clear and what we are lacking is the integration. Is the integration of these tools, the implementation in a good organizational workflows, and to provide a comprehensive patient journey for the patient himself. There is a lot to do, and so we can discuss if we are at 4.6 or if we are still at 4.4, but that's academic. So this general managerial and organizational readiness is missing. And when I look at the panelists today and what they have prepared, I think we get some very interesting views, and we can discuss those views later on. We are talking about ethics. Wolfgang Schinagl is even talking about consciousness. That reminded me of the book I published concerning the subconscious mind of organizations in healthcare and about hybrid intelligences. So it's going to be very interesting. So stay tuned. And I want to hand over to our first panelist, to Professor Florencio Travieso, sorry, I have to read it. And he will tell us about blockchain and what blockchain is going to contribute to healthcare, where the potentials are. We know blockchain from Bitcoin and so on. That's not really something you can easily trust. I think it's a matter of distrust to governments and so on. But the technology behind is blockchain, and there is some benefit we can expect from blockchain, and Florencio will tell us about. Please start your presentation.
Thank you. Thank you, Werner, for the introduction, and thank you everyone in HealthManagement.org for the invitation. I'm going to share my screen, probably as we have all been doing it with on Zoom sessions for the last year or so. So I'm going to go a little bit fast, not fast, but I'm going to just go to the point where we can discuss more. So basically, this is what I think when I think about Bitcoin, blockchain. I think when we think about blockchain, I think everybody, as Werner has just said, we all think about Bitcoin, right? So it's the whole thing that we discussed, but it's like a tip of the iceberg. Under the idea of Bitcoin, there is so much more. And from, as we say, from smart contracts, payments, precisely the idea of blockchain, governance, identity of persons and people, and so on. I mean, many other things. So our work is going to be to try to, unveil and find out what's under the waters. Okay. And when I was researching for a while ago about blockchain, I realized that there is so much to discuss. And in the article that I wrote this last couple of months, basically, I was thinking, okay, is blockchain a solution? It's really a solution. It's just a mirage. Are we being confused? And everybody is thinking, yeah, we are hearing so much about the speculative nature of Bitcoin that we tend to think and rely less on the capacities of blockchain. I'm not going to defend blockchain because from a legal perspective, I'm a lawyer by training. So from a legal perspective, there's lots of issues today about blockchain. So basically, here are some questions that we should ask, and maybe we can include them in the discussion. Can we trust the system? Can users trust the system? There's a lot of people trusting on Bitcoin. We have seen it, another type of cyber currencies, cryptocurrencies. But can users trust the system? Can this be a user-friendly platform? Can we think of that? Is it going to become a way to personalize medicine? Maybe it is. Because it has a capacity of being decentralized and centralized at the same time, right? And this is my last point where we talk about, is it really patient-centric? And if it's really patient-centric, that is going to be the revolution. Because something that I mentioned in the article, and I've been thinking for a while, is if the patient concentrates or the absolute level of power over the data that is being basically circulated, then this is going to be a real revolution. So there are many ifs, but this is these are the main questions that I wanted to discuss. I talk about the system, I talk about the capacities, and I talk about the user. So I'm not going to talk about per se what blockchain is, but maybe some of us or you do not know it necessarily. So blockchain is exactly what it says. It's a block of chains. So it's a lot of chains that are chained one to another, and basically, the interesting thing is that each block is related to the previous one. So basically, there's a code here that is called a hash, okay? And the hashes are transported from one block to the next one. So basically, this block number 2 has the original hash that will be here. The block number 3 is going to be considering the previous blocks, the previous hashes, and so on and so forth. So basically, you're like piling hashes one to one, one after the other. So that is one of the first characteristics. It is decentralized, so it means that there's no one entity that controls the process. There is proof of work, which means that the certainty of the transactions is going to be confirmed by the people operating in the chain that is called mining. Okay, we were going to be mining or verifying these transactions. Are we going to give the proof of work? We're going to give the okay, and then we move on. If I transfer money from myself to Werner, somebody else will have to vouch and confirm the transaction, not just me or him. And then we have the practical immutability, which is very interesting because it means that nothing in the chain can be changed. Nothing in the chain can be altered by no one. Okay, so everything stays. So it's a positive thing and it's a negative thing at the same time. Okay, so these are 3 characteristics. decentralization. No one has the upper hand over the data. There is a sort of global consensus on the certainty of the data that is being circulating. And 3, data cannot change. The data cannot change. So I'm trying to think about what are the positive things. The positive things is that when we think of the industry, blockchain can be present in many layers of the health ecosystem. Okay, so it's very versatile. That's a very good thing. So we can find it in many places. Second, we might be able to unify the identities of patients through different platforms, which is something that today we cannot do, and it's linked to the next point, interoperability, right? This is what we all want in the industry, to be able to basically connect all the pieces of data that are circulating of users, okay? So multiple identities, centralized, and then interoperable. Removal of intermediaries. So this is going to be good because it's basically the patient will have more control, ideally, okay? A consequence of this is going to be the cheaper transaction costs. Okay? So the system is going to be technically cheaper, and data can be updated immediately, okay? That is also going to be a positive thing. So we don't need to wait for data to be updated or corrected or verified. And finally, it is a smart contract ready, which means basically that transactions can happen very fast and very effectively, because we have the technology. Blockchain allows to make simple contracts very fast. And in terms of transactions for healthcare, that will be a positive thing to do. And then last thing, the supply chain control, okay? That is going to be allow us to track supply chain of medicines and avoid a counterfeit. Negative things or questions or limitations, very recent technology that is linked to the assimilation to cryptocurrencies. We trust them less, okay? There's an element of, okay, the big groups are going to take over this technology and they're going to do, they're going to monopolize again their power and activities, and the power of users might be lost in a way. The other problem from a legal perspective is that we cannot change the data, and we cannot erase the data. So that is a problem, because under GDPR, the data protection regulation in the European Union, we should be able to erase that data if we want to, if users want to. Today with blockchain, we might not be. That might not be done so easily. And lastly, basically, we have still cybersecurity risks, even if they say that it's very trustworthy, there are still issues of keeping networks and databases safe. Quick conclusion, it is good that we can democratize the circulation of patients' data. It is good that it's a non-centralized network because we place the user in the center, something that we have been discussing for a while. It is great that it's going to be agile enough to be used for new problematics. Okay, we can use this to track certifications of COVID vaccines if you want. And it's going to be basically, in the end, we hope that this is going to be giving more trust to the patient, and that's basically going back to the beginning, basically, which is trying to develop more positive technologies. So that's my quick 5-7 minutes probably, and I thank you so much.
Thank you very much. Very interesting contribution. So we will discuss all contributions at the end. So please note your questions and or bring it in the chat. So I would like to hand over to our next panelist, to Diane Whitehouse. She will tell us about how to empower communities to support telemedicine programs. And from my personal experience in our group, it's really easy to generate the technology that you use that you need for telemonitoring. But to bring it to the people and to bring it for them to use it is a real challenge, especially when you have chronically ill patients. So I'm very curious what your views on that will be. Diane, please take over.
Thank you very much indeed. Thanks for the welcome. Thanks to HealthManagement.org for the invitation. And thanks to Henrique, which is from Saxony, Germany, and Ertel for the support here. Well, from the technological start of this presentation, and the lots of numbers, the 4.6 that Werner has so kindly started with, we're moving to a more social and societal angle. And I think we will see this kind of hybridization come to the fore in the discussions that the other panelists also follow on with. This presentation is really about the work of Dr. Lena Otto from Dresden, and focusing on telemedicine community readiness models. In particular, the one that she and her colleagues have developed that's really beginning to prove its worth in terms of its application in the telemedicine field, expanding telemedicine, enlarging its use, and really encouraging its use. We very much use the current COVID-19 pandemic situation as the kind of threat and opportunity at the same time, and explored together the kind of barriers and success factors that are at play here. I don't have PowerPoint slides. Nevertheless, I would encourage you to read not only our own article, but all the articles of our colleagues, which are generally short and brief and to the point as well. So we have looked a lot at hybrid care, the bringing together of virtual or digital technologies and physical face-to-face care as well, in both health and in care encounters. So really integrating, merging, bringing together, blending the two. And I think probably today's challenge is what will happen next, not what will the soi-disant new normal be, but what will the next normal be? How will we go ahead with this? And I'm fascinated to know that I have fellow panelists who will be focusing also on smart hospitals and smart hospitalization. That's certainly an area that interests us in ETAL, the European Health Telematics Association, and interests many other people too. So focusing on this telemedicine community readiness model, it has several stages. Many of the models that we're looking at today have phases and stages. I think that's a kind of commonality to almost all of them. The use of telemedicine community readiness models has been increasing and is in use in example countries such as Israel on the one hand, Scotland in the United Kingdom on the other, and also, and we will hear more from a colleague in Portugal towards the end of this afternoon. What do we mean by community? We mean both geographically located communities, organizationally located communities, but we also mean communities that share certain concerns. And just on my side, hearing an ambulance go by there, some of those shared concerns can indeed be around particular conditions and diseases, including not only common ailments, but also rare conditions and rare diseases. So who can use this model? Almost everyone can, just about everyone. Nevertheless, we looked at how the model interoperates with various personas. Personas classically in the user-orientated area have focused around patients very often as end users. Increasingly, and certainly Lena's work looks at this, have been looking more at various professionals, including working adults and including particularly young working adults. So you will see in our article that we draw on a very interesting persona, Lena, age 27, who really uses then the community readiness model and is inspired by getting more and more involved in integrated care and in her own community. In order to really bring virtual and physical together. 3 sites worked with Lena to apply this model. One of the really interesting ones was an Australian example with a very diverse community, very racially diverse, very socioeconomically diverse. Another, interestingly, was from Zagreb, the city of Zagreb in Croatia. And last but not least, close to my own heart, Scotland, with its very interesting national Scottish government programme and financing. All were at a fairly advanced level, level 4, phase 4, all were inspired to want to go further and to really mature telemedicine use in their areas. As a result, therefore, Helict, H-E-L-I-C-T, the local Dresden and Saxony Center of Young Researchers, is really keen to take exploration of this model forward. And we too in ETEL are very happy to support them on that. Werner mentioned the word culture. I can't say we explored that in any depth in our article, but I think particularly looking at areas of work like behavioral science, nudge theory and nudge techniques, and also not only economic incentives, but very much non-economic incentives are all areas that could be explored further. We have many other models and techniques and instruments in our back pocket, including those of Scirocco exchange, including those of momentum, but nevertheless, won't go into those in detail now. Apologies from Lena that she can't be with us today, but very much looking forward to the dialogue with colleagues here. Thank you very much indeed.
Thank you very much for your contribution. So we, as I said, we may discuss it after the addresses from the panelists. So the next would be Fenna Heyning. She will tell us about value-based care and about the full cycle of care. That's what I meant in my introduction with integrated care, with those the crossover problems we have here. So we are very curious for your ideas. Please take over.
Yes, thank you. I will share my slides with you. Thank you very much for the invitation. I do think that you, Werner, and the previous 2 speakers have already stressed the importance of integrated care. And I would like to add my perspective to that. As said, I'm trained as an internist. I specialized in hematology. And I would like to start with this slide showing a quote from Atul Gawande, with whom I'm sure you are familiar, the famous surgeon in the US and a well-known keynote speaker. He wrote this in his book, Being Mortal. We've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that. It is to enable well-being. And I think I couldn't say it more concisely and precisely than he can. So I'd like to stress this quote during this discussion. And obviously the COVID pandemic has only stressed the relevance of this quote one more time. And then I'd like to jump to slide number 2, which is also a quote or an article by Atul Gawande, which came out in 2018. And to be a little bit provocative in this context, he stated that doctors hate their computers, and he goes into details as to why that is so. In my environment, it hit home. Doctors, at least at that time, really emphasized and identified with this statement. Of course, seeing the benefits of computers and EMR systems, but also feeling in their personal workflow that they were blocked rather than helped by the computer system, and feeling that it literally put a screen between them and the patient. So hence this question, do you recognize this still in your current work environment, or can we say, okay, that was 2018 and we live in a different era now and that has become obsolete? I'd be interested to hear from you about that. And then I'd like to switch to slide number 3, which is an artistic rolling into one of, if you will, the famous value agenda by Michael Porter and Elizabeth Teisberg, which is a pentagram, if you remember, stressing to, in my perspective, the most important fact, as Werner said, value-based healthcare is looking at healthcare from over the full cycle of care. And I think, as Diane also stressed, you could also propose the question, how wide is the domain of the full cycle? We tend to call certain things within the social domain, but one might say that should include the cycle, which we call healthcare delivery. And for example, if you go for a run with your Fitbit and your smartphone and you put the data in the system and in the cloud showing the rest of the world how far you went, how fast you went, is that personal data? Is that cataloging your hobby? Or can we also interpret that as medical data telling your physician very important things about how well you're doing? And the other theory and line of thinking that I would like to stress here is the thinking of Don Berwick. He is a famous pediatrician, also from the US. He later became the first president of the IHI, Institute of Health Improvement. He was the one who wrote about triple aim. But in 2015, he wrote an important article discussing era 1, 2, and 3. And in era 1, he describes it was the era in which professional dominance was how things worked in healthcare. Doctor was God, mostly they were male. They worked really hard. They were always available for their patients, but discussion, shared decision-making, integrated systems were not very much part of that thinking. And then we moved into era 2, which became the era of accountability, of measurements, of focusing on process parameters. And to many professionals, it felt like a loss. They lost their autonomy. They felt they were losing trust. Society didn't trust them anymore. So both camps, they became camps, have very strong advocates and strong adversaries. And Don Berwick proposes, and I couldn't agree with him more, to enter era 3, which he calls the moral era, in which we give back some autonomy back to the professionals. We do trust them. We leave them room to be the professionals that they were trained to be. But we ask them to allow a little bit of room for accountability and measurements. And I would call it, in my words, human ecosystem. And I think back to technology that cannot function at its best without technology and all the possibilities that, for example, but not limited to, digital platforms can do. If we manage to integrate those two and really look at the system from an integrated point of view, we really and truly enter the human moral era. Thank you. That was my introductory talk for now.
Thank you very much. So you gave a wide answer concerning the topic of how to integrate technology in our daily work, especially from the physician's point of view. So that's why it's going to be very interesting what Wolfgang Schinagl now tells us, because he will tell us about artificial consciousness. So let's see what he's going to tell us. Please, Wolfgang, take over.
Thank you, Werner. I will just share. Artificial consciousness, or I would say beyond artificial intelligence. And so I have to go to the next slide. And I want to take a comparison between natural human consciousness and artificial consciousness. And yes, the humans, we are the humans, the mind's eye, the self, the personal identity is what we call natural human consciousness. And on the artificial consciousness side, we have a philosophical hypothesis that current artificial intelligence without consciousness will never create human-like knowledge. On the natural side, the consciousness has been developed by evolution: genome, transcriptome, proteome, metabolome, microbiome, and especially connectome. And everything was driven by self-organization. Everything on the artificial side is driven by ideas and hypotheses of scientific individuals and teams. On the natural side, we have the brain, the wetware, the connectome. And on the artificial side, we have the hard and software, the artificial neural networks and the upcoming neuromorphic hardware. On the human side, we have general intelligence. We have the typical human perception, imagination, emotions, wishes. And on the artificial side, we have lots of problems, unsolved problems. The binding problem, the representation of mental states, phenomenal consciousness, the qualia problem, the intentional consciousness. But we are the real humans, the experts, and on the other side, there are the robots in science fiction or the digital twins. What is the critics? Healthcare today ignores widely individual consciousness and personal identity. Why? Because, of course, it's not necessary. Important are medical data and its impact on healthcare. The medical success is dependent on evidence-based diagnosis and well-proven therapy. Today, healthcare focuses primarily on medical statistics, big data, massive data analytics, pattern recognition, mathematics and algorithms, expert systems, machine learning, deep learning, all fields of artificial intelligence. And the reasons are: René Descartes in the 17th century separated body and mind. And of course, focus on consciousness is very expensive because of cost-intensive human resources. The holistic approaches are still seen as nice, but inefficient and counterproductive. What is open through? Think of esoterics. The future of healthcare is individualized medicine. This means that we are setting up digital twins, which is a data set, a data cube, or a data lake. And data sets of digital twins are periodically the digital self-tracking and self-measurements in time and space. What do we mean by self-tracking? 3D body scans. the whole imaging and the pictures of the radiologists, quantifying physical activity with watches, the whole genome sequencing, the biological fluid testing like blood, urine, sweat, saliva, sputum, and so on. The result is a quantified self, which is a historical and real-time data set as a real type in comparison with a statistically accumulated healthy similar digital twin to myself as an ideal type, the Max Weber distinction, for instance. The next step is the combination of the digital twin with an artificial consciousness advisory system that really knows about the meaning of the data and guides you individually to change your behavior, what to eat, how to move, how to live, how to work, how to sleep, and so on. Last slide. The evolution of doctors and healthcare. Yes, today we have the real humans who are certified by the medical universities. Some net doctors already use medical expert teams, telemedicine with real humans and colleagues. In the near future, we have AI-assisted doctors. They are using expert systems, machine and deep learning, especially pattern recognition, of course. And in the near future, we have the robot doctor generation 1, without artificial consciousness, of course, and no impact on personal identity. But they simulate already personal identity with chatbots, which know nothing, of course. But in the far future, we have the robot doctor in the generation 2 with artificial consciousness, and such a system is able to mirror qualia, to really understand even psychiatric illness and disorder, being more a friend, partner, or better expressed, a guardian angel, because he or she really knows about your medical state, mind and body. Thank you for your attention.
Thank you very much, Wolfgang, for your philosophical and far-reaching views. I'm 64 now. I wonder whether a robot doctor too, if I ever will meet him. But I think it's a very good input for our discussions later on. And now I wanted to check if our next speaker, Henrique Martins from Lisbon, is already here.
Yeah, I'm here.
You're here. Welcome. Thank you for taking part in this discussion, and we are very curious what you are going to tell us about a social network of health. Because for me, social networks are connotated very ambiguously. So I'm very much looking forward to your presentation. Please take over.
Well, thank you very much. I have prepared a few slides on a slightly different topic, but I think I'm going to do different without slides. Basically, the question right now is one of misinformation. There's significant problems on fake news, and WHO has called the infodemics problem. The question at hand right now, and the debate I discuss in the paper in this issue, is the issue of the right to freedom of speech, and the fact that most of our freedom of speech in social media is actually moderated by private platforms. So currently, we have most of our public speech online is actually not public at all. It is privately owned. It is run by a set of companies, all of which are outside the EU. And the question that I pose in that contribution is whether the way forward to really secure freedom of speech and the quality of information is to have the courageous step to use the new regulation currently being discussed on the European health data space, and within that data space to create what I call health social space. So basically a sort of Facebook of health. But the big difference about this is not technological, it is the ownership of the platform and the rules, terms of conditions. So right now, most of us have online presence by signing a term and agreement with a private firm, which then has and holds the right to modulate many of our posts. There is actually very little state or EU law controlling the way private platforms moderate public speech. So I would actually argue that there isn't public speech in that sense, as it is in the street, because in the street there is no one that will take our voice away. So in conclusion, the idea that I outlined in that paper is that people say, well, it's too late. Most Europeans are already on social media and on social platforms in the US, and they're not going to use a platform in Europe. I don't think that's the case. I think it is possible to create online, publicly ruled space where professionals, patient associations, and patients, individual patients, if they wish so, collaborate as they collaborate today on Facebook or LinkedIn. The big advantage is that the rules, the terms and conditions, and the way the system could be operated could be governed with the participation of patients, professionals, and state authorities and EU authorities. To conclude, this would increase, in my opinion, two things: the quality of health-related information online, and more importantly, the traceability of those posts and the auditability. How to do this? Actually, it's not that difficult. Today, most of people that collaborate, for example, with the European Commission already have a digital identity to use European Commission portals. Most professionals could register voluntarily, and this could serve as a European-wide professional registry, voluntary professional registry, and then patients as well. And finally, this could be a platform for patient donation, data donation. If the patient wishes to collaborate on data donation or data funding, let's call it this way, crowd data funding, they could do so by aggregating their data with their profile with selected groups of patients on a trusted, publicly owned platform, and not to do this on a privately owned outside the EU platform. That's kind of the challenge, and thank you very much for the time and allowing me to share this vision.
Thank you very much. So we really have very visionary views today to discuss, and I would like to ask the auditorium to send me some questions. Otherwise, I will have to put some questions. Because thank you for being so disciplined in terms of time. So we have now very much space to discuss and to conclude, which is a hard job to moderate. As I have no questions up to now on the chat here, I would like to ask Florencio. We know from Bitcoin and Bitcoin mining that this is a very energy consuming business. When you envision your applications for blockchain in healthcare, do you think there will be a discussion about that too? Or will these blockchain applications be much less energy intense compared to Bitcoin? Because I think it's probably not suitable for healthcare to consume such big energy resources.
Thank you, Werner, for the question. It has been discussed, the energy war quality of mining, and it's a very good topic. However, to answer quickly and allow the conversation to go on, is that there are today simpler and less polluting or consuming technologies that are allowed to mine in a more, let's say, green way. I believe as well that probably in the next 10 years, there will be ways to find more efficient and less CO2 polluting methods to do this. Today, probably I think that today the main goal for all the actors in the industry is to turn this I'd say this technology into something into something friendlier and helpful and useful. Then we will find out the solution, I'm sure.
Thank you very much. So now I've got some questions. One question is, when we implement all these useful advanced technology in healthcare, including blockchain, how much the budgets would have to be increased for the healthcare systems? Are there any opinions on that in the board, with the panelists?
I can contribute to that, at least from my previous experience heading digital health in Portugal. Many of our projects were actually cost effective. For example, the National E-Prescription project, we had to deliver important report in the National Court of Auditors, and we showed savings of millions. So I think it is possible to shift the changes from the budgets, and definitely prevention does work. And digital prevention saves a lot of money, for example, anticipating, for example, early treatment in cancer. So I honestly think shift in budget, yes, which means we have to bluntly say it, shift in lobbying. And of course, lobbying for fixing these shifts and avoiding shifts is a big problem that we need to find ways to solve.
Okay, maybe I can add from my point of view as former CEO and now CIO again at Carges, a big hospital provider with 17,000 people, covering a healthcare region of about 1.2 million inhabitants. I think we are quite advanced in the usage of these technologies. We are maybe at 4.2, not at 4.6. But we currently have about 2.3% of our annual expenditure for the whole group, for all the hospitals. 2.3% are IT costs. And I think there is some room left to shift data. And I agree with Henrique. concerning the lobbies. Yeah, and when you look, when you take these costs to an inpatient, it's about 120 euros per inpatient, who costs you between 2,000 and 8,000 or 10,000 euros. 120 euros are for IT expenditure. So I think there is room left to augment this, but it's there's a lot of lobbying under the way, and I think the more digital transformation strategies take place, the managements are more and more willing to invest. So I have another questions here on the chat. Is there a role for industry? How do we change the status quo? Maybe somebody asked from Facebook if there is a role of industry when I look at our last presentation from Henrique. So has anybody in the panel an idea to that? Diane, please.
I'm going to try to talk and hope that I'm going to be heard. Okay, great, perfect. I think we're talking more about public-private partnerships, yeah, and it's clear that industry has a role to play as one of the many stakeholders in a multi-stakeholder environment and a multi-stakeholder platform, to use Henrique's view. I personally think the challenge, if you want, is more about whether we're talking about big industry or also micro enterprises and small and medium-sized enterprises. I think all of us today, at least on the panel, are European. That's not necessarily true of all our audience. But we know what a large proportion, what a large role small and medium-sized enterprises play, not only in the European economy as a whole, but in health and care specifically. I think there's a real set of questions there, particularly when our institutions are focusing more and more on what can we do with young entrepreneurs? What can we do with small businesses? Will they really continue to survive into the future? Is there a role for them there? And I think other people on the panel are probably more skilled with their business or entrepreneurial background to have a view there. But I think it's certainly an extremely moot point.
Okay, thank you. Some more opinions from the panel?
I have a quick comment, if I may. Basically, they were asking, what is the place of the industry? I would say, let's take the example of Amazon and how Amazon, in probably like 20 years ago, shifted the way retail was done in the USA and in the world. And basically, now Amazon is entering healthcare, and basically, what if we will experience in the next 20 plus years the same, or even less, the same progress or progression of simplification of processes? And Amazon has an amazing, well, I shouldn't categorize it as amazing, it's just very strong supply chain capacities. So there's a block of the industry, layers of the industries that could be solved by the application of Amazon. I'm not saying I'm not pro Amazon, I have no shares there, but I'm saying that there is something to pay attention to. So I let everybody else to jump in, basically. What would be the role of Amazon in the industry? How would that change?
Okay, from my point of view, we should be very careful handing over healthcare to those big monopolists. I agree with Travieso that Amazon is absolutely strong in big data, is absolutely strong in the logistic chain, and it would like to be very strong in personalized services. And it clearly has the potential to bring personalized medicine to the patients. But we always have to envision, do we trust this? Because are the offers from Amazon really just driven by the best for the patients, or are there other motives behind? I'm not sure that people will really would trust such a monopolist system. So I hope that the public authorities stay in the driver's seat and don't leave that to Amazon, Google, and so on. I would be very, very careful there, because I heard somebody saying, take Amazon, Google, or SAP, it's the end of markets, because they are building up monopolies, and finally we will end up with innovation too. So Fenna, you have your hands up.
Yes, thank you. I was actually interested in a question that came in the Q&A. Are smart hospitals a solution or a barrier for healthcare professionals? But maybe Henrique should first do his comment referring to the last question, or?
No. Well, it's a quick thing, just a provocation. NHS in some countries is also a sort of monopoly. And sometimes public monopolies, are also not very innovative. So I think, going back to Diane's question, I think we need to start thinking, I would use the word not just public-private partnerships, I would say new innovation in public-private relationships. I think we need to reconceptualize the way in health we live with public and private. And I think this calls for the regulators in town, which have been absent. The so-called health regulators in many countries. You have a strong ministries of health in some places and national services. In other places, strong insurance companies. But the regulators, I don't think they've been developed. The regulatory function, perhaps what is missing in this ecosystem. So that's it over for me. Sorry, Anna, go ahead.
Yes, thank you. I think this is a very interesting question. I'll repeat it again. Are smart hospitals a solution or a barrier for healthcare professionals? And tying into my provocative slide from Atul Gawande, at least in 2018, many doctors state they hated their computers. So from that perspective, it would be seen as a barrier. And I do recognize that sentiment in the current day. Personally, I think a smart hospital, which I interpret as mostly digital, but surely there is room for a physical interaction between healthcare giver and the patient, is a fantastic solution. But I think it's very important if we change or transform one segment of the full cycle of care that I talked before, and we expect the rest of the chain to stay as it was, it's not going to function very well. And I think then all the other segments of the chain will rightfully comment like, oh, now I can't do my work anymore like I used to do. So if we change one thing of the balance, I think we must take a look at all the other segments as well and ask the people who are active in that segment of the journey, what do you need? And if we work more remotely as caregivers, what can we change? How can we make the case complexity more interesting for the highest trained doctor? How can we make sure that everybody gets to operate at the top of their license? How can we make sure that when you do see a patient physically, you have enough time to actually pay attention to that particular person for more than 10 minutes? And within those 10 minutes, how can we make sure that you're not typing away behind your screen for 90% of that consult with the patient? All those things. If you solve those problems, as yes, in other sectors, such as retail, tourism, finance, others have fixed, then we are going into the right direction. Thank you.
Thank you. Wolfgang?
The problem is, and Werner, you stated this about this problem already. The main question is who has access to the data of the individualized identity of the human, of who has the access. And at the moment, the self-trackers and the self-measurers, they store it in the cloud, so he or she is not the owner. And on the other hand, there will be the doctor in the healthcare system, in the hospital. But these people have no access to this data. And now a new trend is coming up. For instance, the genome, the full sequencing of the full genome, which is now available in a quality which is absolutely incredible for under $1,000. And so people have now personal data about themselves. And now this is a treasure, of course, for scientists, for doctors. But who has access? Who can do something with this data? How can it be used for curing the people? And this, I think, will be one of the main questions. And I discussed with people from insurance companies, health insurance companies, and they discuss already how they can set up own systems, completely distant from traditional healthcare systems.
Thank you. I know these developments. There are some promising approaches in Europe with the EU health data space. And when you look, for example, to Finland with the FinData agency, they have tackled this problem being within the GDPR regulations. So there are ways, but it's very hard to find ways in Austria and in Germany due to our history in World War II.
Yeah.
Diane, you raised your hand?
I did indeed, and it relates back to Fenna and the coverage of private hospitals, the question posed in the public chat. I think what's interesting in terms of trends and developments are when you look at what is happening in the new, very large, very expensive hospitals with superb technologies. I'm thinking of a visit I made to an extension of the Karolinska in Stockholm, really, startling and impressive versus what's happening in our local, one might call them cottage hospitals or local hospitals, and this kind of polarization that's occurring between the large, the wealthy, the highly technological. The other trend, and I don't know to what extent we've explored it in HealthManagement.org, but is really about hospitalization at home. So the shifting, in fact, of health and care to our own rooms, our own houses, our own homes, our own households. And how smart will they be able to be? How smart will we be as our own carers and our own providers of support to ourselves? So I think there are some moral and ethical questions involved there, not only economic questions. Thank you.
No, I agree with you. There are structural problems in healthcare systems. In Styria, where I come from, we have the university hospital and the cottage hospital, as you call it, in one company. So it's easier for us to implement digital strategies in order to bring the best knowledge to the hospital bed somewhere in a rural area. That's our aim, but to accomplish it is a second. Is a second
I think
challenge. I'm sure that the technologies will help us in that, and I think with our experience with COVID, the acceptance for what you call hospitalization at home, with all those new technologies in diagnostics at home, there will be a movement in this direction. And the hospital providers will have to think about what role are we going to play? What role are we willing to play? And I'm very curious what's going on there in the next couple of years.
I think it's excellent to look at good practices, and you're citing your own region in Styria in Austria. So it's great to look at where are the good examples that one could explore and mirror. Absolutely. Yeah. I did get a warning sign a couple of days ago in a conference that I think probably Henrique was in as well. And I will not name the very large, very sophisticated hospital in the US. But the message from the audience was things are very different there. So let's look at our own continent and our own examples. Thank you.
Are there any more contributions, Henrique? Because I would come to a summary in the end, because we are running out of time and people are already leaving, as I see in the. So Henrique, please.
Just a quick comment to say that, for example, here in Portugal, we had a national project which was stimulating hospitals to move to digital, and actually, some of the smaller ones did a better job. The fact that they were, of course, we needed some funding, but the fact that they were small enough, they were able not to just use the technology, but change the processes. I think there are examples of cottage hospitals, to use your expressions, that make us think it's not just the IT itself. And sometimes a smaller one, because the teams are more close by, they do more hybrid. To use Wolfgang's expression, they are more conscious of the value of money, and they explore the technology better. And I think this is key. Exploration of the technology will make future health better, not just having a lot of technology on your shelves. And I would like to finish with this.
Thank you, Florencio. We don't hear you.
There you go. I'd like to finish a question that was asked or relayed by Sherry. It says, telemedicine has played a huge role in provision of care during the pandemic. What do you think this is going to continue? I just want to give my 2 cents here. Of course, everybody used the telemedicine almost, forcefully. But I think that there is a big portion of use of telemedicine. This is always what I'm saying. It's going to be kept, and also it's going to be complemented not only by new services of telemedicine, but also by add-ons. There's new technology that is being created to scan almost wounds. You can take a picture of your wound, and then it's going to be analyzed. Therefore, there's a whole business happening from distance medicine, more than telemedicine as a consultation. The whole care is going to be developed in distance. So we are going to be witnessing a revolution in terms of spreading of applications in this sense.
Okay, so thank you very much. I'll try to sum up it a little bit. We were talking about structures in the last part of the discussion. In the structures from the provider side, from the market side, but also from the hospital side. And I think I'm very much with Fenna Heyning who spoke about the moral era. We have to keep in mind that the structures have to serve the people, and not people have to serve the structures. Because from my experience, we often do the second thing. We have to shift it that the structures serve people, and not that healthcare professionals have no freedom to act. Yeah, and there is a danger concerning with highly automated procedures that they lose their freedom to act. And I think we have to keep an equilibrium there, a balance, to find a balance there. So we also spoke a lot about empowering hybrid care, and we discussed some aspects where the word trust came in. What do we have to do that our healthcare system can be trusted? Can we trust, for example, Amazon? I'm not against Amazon, but as a pass pro toto, can we trust that it's the best for us, for the individual person? And the blockchain technology may maybe help us to implement more trust. And we also heard about artificial consciousness. Thank you, Wolfgang, for your contribution here. And I'll bring it together with Fenna again, who spoke of the moral era, where trust is of high, and accountability and giving room is very important. And I thank you, Wolfgang, for this comparison between artificial and human consciousness. I think we will have to find the right way in hybrid care, and for all especially in the support of our healthcare professions, of the healthcare staffs. And I think when we come to an era where artificial intelligence makes human intelligence more valuable than ever, then we are on the right way. But there is a lot of danger on the way there, and we have to be very careful that we don't lose the right way, to stay in the driver's seat as humans, and to really find to the goal that artificial intelligence makes human intelligence more valuable than ever. And that's, I think, a nice close-up for this discussion. Thank you to all the panelists to take part in the discussion. Thank you to the auditorium who stayed to the end. And thank you to HealthManagement.org to organize that. Have a good evening. Goodbye.